The patient came in, he had an elevated temperature. We tried to assess his blood pressure and it was extremely low. At that time, Dr. Saad and I determined that he needed central access to deliver these fluids and medications to his heart directly.
His vital signs were extremely low. Blood pressure was below 90, and that's usually concerning for us because when you see that, then we need to immediately intervene at that point.
Upon arrival, we determined that the patient had a bad infection. He had an elevated temperature and his blood pressure was extremely low, consistent with what we call sepsis. We determined that it was imperative that we place a central line in order to access the patient's heart to deliver IV fluids, antibiotics, and vasopressor medication. So in order to perform the procedure, we sterilely drape the patient, and then with ultrasound guidance, we determine the vessel which we want to insert the catheter into. After performing a chest x-ray to ensure adequate position of the catheter is when we begin administering the IV fluids and antibiotics.
The patient's presented vital signs were extremely unstable and very life-threatening. His blood pressure was being monitored only by a blood pressure cuff, which for most patients you can use if they're stable. However, this patient was extremely unstable. We warranted the need for an arterial line for blood pressure monitoring.
He came in with a very low blood pressure. Obviously, that's very dangerous. We need to get the blood pressure up immediately. We also need to monitor that blood pressure. So after he was given fluids, his blood pressure came up enough that we could feel pulses. At the place where you can feel the pulse, you take a needle and you access the artery. And then after you've accessed the artery, you can put a guide wire into the artery and then slip a catheter over the guide wire. Then you can pull the catheter out, hook it up to a monitor that measures the blood pressure.
This gentleman was extremely sick and required admission to the ICU. We had him stabilized with blood pressure medications. We've given him IV antibiotics for his urinary tract infection. And we had to have consultants on the case because that low blood pressure and the overall sepsis, which is the major infection that he was having, caused injury to his kidneys, heart, and to the brain. So we had consultants from every field of neurology, cardiology, and nephrology to consult while the patient was in the ICU. In reviewing the patient's records, he was admitted for nearly 2 weeks in our intensive care unit before he was transferred from here to a select care specialty center.
Mr. Alpha 105, Party 1.
Mr. Alpha 105, Party 1. McLaren Macomb, go ahead.
McLaren, Mr. Alpha 105, we're transporting an 80-year-old male from a local nursing home, unresponsive. Staff said last seen half hour ago normal, but we're not 100% certain on that. Baseline is confused. Current vitals are pulse of 94, normal sinus. SpO2 is 74, but we're getting a poor waveform. He's on an IMR breather. Blood pressure 48 over 22, 48 over 22. IV established, we're giving fluid. ETA is about 3 minutes. Sugar is 214. Require anything further?
Sorry, what is the oxygen saturation, please?
I'm sorry, can you repeat?
Is he completely unresponsive? And his oxygen saturation, please.
Best oxygen saturation we can get was 74% on an IMR breather. He'll open his eyes slightly to painful stimulation, but barely responsive.
And do we know his code status?
Focus.
And how many lines do you have?
We have 1 line. We're trying to get another one. We have an ETA of 2 minutes.
All right, copy that. McLaren Macomb's clear.